We had an exciting session 1 for the sacrum dysfunctions, sacrum on the ilium called as sacroiliac. Okay. Ilium on the sacrum, abnormal positions of the ilium, which is called as iliosacral, and pubic symphysis dysfunctions, which are one pubis abnormally behaving with respect to the other. Okay, so that is pubic symphysis dysfunctions. Right? Dr. Poonam, are you ready? An enrolled participant of the clinical pathomechanics course. Madam, whether she is able to join us. Yes. Good evening.
गुड इवनिंग सर।
Yeah.
एक्चुअली मैं विजिट में थी, इसलिए मैं वीडियो कॉल पे नहीं आ रही थी, क्योंकि फिर हल्ला होता है और सामने से रोड जा रही है।
नहीं, आप माइक्रोफोन को म्यूट कर सकते हो।
ठीक है।
इधर सामने माइक्रोफोन है ना, सिंपल वीडियो ऑडियो, ये सेल्फी कैमरा स्विच करना, ये सब। So if there is background noise, you can always mute the microphone. Only when you talk, that time you can unmute. Okay. And Ritu ma'am is also joining. Right. So now this topic here, now this section of the webinar is Piriformis syndrome. Okay. So which is actually the most commonest conditions. Most of the physical therapists who are working for 2-3 years in clinical practice definitely will be doing some treatment or the other, okay, for Piriformis syndrome, which is like release, especially mostly they'll be doing with the elbow and moving the thighs, okay, hip into internal or external rotations. Some people might also be even thinking of cupping on the Piriformis. Those who have done advanced training like dry needling, they might also be doing needling of the Piriformis. Okay. So every intervention there is a scope of practice there. Okay. Of course, the muscle is originating from ventral surface of the sacrum, okay, the anterior part, and then it goes via the greater sciatic notch, okay, and then gets attached to the, this is gluteus minimus, okay, so getting attached, okay, and to the trochanter, okay. So the sciatic plexus, the sacral plexus and sciatic nerve again comes through the greater sciatic notch like this. So that is again closely related here as it comes, okay. So it's a very, very densely crowded area. Medius, minimus, all of them are attached to the trochanter, and you can see even anteriorly or the lateral part, which is the tensor fascia lata. Okay, so that is also present here. Okay, so anteriorly. So the one which is cut here is the gluteus maximus. Okay, so that is actually cut and removed, superficial. So apart from the neural relationship and of course the ligamentous relationship, because sacrotuberous ligament is very closely interlinked with the piriformis. Sacrospinous ligament also, it's actually, you can see sacrospinous ligament, sciatic nerve, piriformis also comes here only. Okay, so that is also very closely interrelated. And as we have already seen that sacrum dysfunctions can definitely affect the piriformis muscle length between right and left. Okay, imagine that if the sacrum is shifting towards right, so that means right side piriformis will become tight and the left will become taut. And we have seen that as assessments. When you give contractions, if the length improves, the flexibility of the muscle improves, it is tightness. You give contractions, the muscle flexibility is not improving, It means it is tautness. Okay, both can restrict the movement. And above which, of course, piriformis is related vascularity. Okay, as we see supraspinatus tendon in the shoulder, the muscle fibers broader origin. Okay, supraspinatus, and then it comes to narrow insertion of greater tubercle, and in between the fibers actually twist the supraspinatus. Same way here also, sacrum, it is broader origin, piriformis comes like this, and the insertion, it's a very narrow area in the greater tubercle. Okay, so there also there's a twisting of the piriformis. Okay, so on a closer look, if I am keeping the femur and the sacrum, okay, and I will show you in a different dimension, a top angle view. Okay, yeah. So now you must be able to see the sacrum and the femur. Okay, posterior aspect, and this is sacrum. Let me fix the piriformis for you using this blue adhesive tape. Okay, starting from sacrum to the femur. Okay, so I'm taking the tape. Okay, so I'm going to take it from the greater trochanter. So I'm going to put it here. Okay. Okay, this is the posterior surface. This is also posterior surface. Okay, so it goes all the way to the anterior surface. So I cut like this. If I have to take these fibers to the anterior surface, that means I have to twist it and stick like this. Okay, so that is one single fiber of the piriformis from sacrum to the greater trochanter. Another set of fibers, I can again start from the sacrum, the trochanter, take it, and as it goes to the sacrum, I need to again twist. So I will cut it and then twist it. So this is the actual. Okay, so insertion is posterior in the greater trochanter, origin is anterior in the sacrum. Okay, so the piriformis comes like this, and also it does not attach to the capsule of the hip, but remember that it has a very close relationship with the posterior ligaments of the hip, like ischiofemoral ligament. Okay, so that is posteriorly present in the hip. So here the tape is stuck to the femoral head. Okay, pardon the tape. So imagine that from this position, if I am supporting the femur, okay, and taking it to a little lower level, okay, so from here, so this is posterior view, piriformis. I can take the innominate bone, okay, and keep the innominate bone, the greater sciatic notch. Then the whole system gets completed. Okay, so the actual piriformis, how it comes through the greater sciatic notch. Okay, there is no attachment of the piriformis to the innominate bone. So all I have to do is keep the greater sciatic notch, which is this portion of the notch, okay, posterior, where my middle finger is, okay, and I keep it like this, so it becomes the piriformis muscle that is coming all the way from posterior to coming anteriorly to the femur, okay. So, right, let's check the status of Ritu ma'am. What is her internet? Okay. Dr. Poonam is also moving around. So, Ritu ma'am, are you able to text whether you are able to see my audio and video? How is your internet? Kushbu is also there. She's not ready to come on the screen. You are able to hear me, Dr. Poonam? Audio video is fine? Okay. So this attachment from anterior to posterior, okay, because anteriorly in sacrum and posteriorly to the femur. This makes the functional mechanics of piriformis to be a paradox. So in what way it is paradox? That means if, for example, the femur is neutral, okay, so if it is neutral, the piriformis will externally rotate, okay, but when it is flexed beyond 60 degrees, so this is 0, this is 90, so 60-degree flexion, the fibers of the piriformis which are posteriorly there, like this to the trochanter, will shift anterior. And because of that, piriformis becomes an internal rotator of the hip after 60-degree flexion. Before 60-degree flexion, fibers will stay posterior, so it will stay as the external rotator of the hip. So it depends on the position of the femur. So if you keep it flexed at 90, it is an internal rotator of the femur. If you are keeping it at neutral or extended, it is a external rotator of the femur. So remember this. So because you need to know the action of this muscle, then only you can assess this muscle. And that is the reason why some patients have symptoms in hip flexion. They don't have symptoms in hip extension. Okay. That means like standing, they don't have piriformis pain, but sitting, they have the piriformis pain. Okay. So that means it is a 90-degree flexion. So there, piriformis is an internal rotator. So piriformis will be tight in internal rotation. It will be tight. So you have to stretch, that means you have to externally rotate the femur in 90-degree position. Okay. You cannot treat the piriformis in neutral position and expect that you will get improvement in sitting symptoms. Okay. Same way standing, and then the piriformis syndrome comes, the symptoms of piriformis. Gluteal pain is there. So that means it is extended femur. So that means it's an external rotator. So piriformis is tight in external rotation. With external rotation it is. So you have to check its length. You have to lengthen it by internally rotating the femur in hip neutral position. Okay. So that is why which standing pain or sitting pain is a basic question which you need to ask. If a patient tells pain at the piriformis region, means don't start palpating with the elbow, start releasing with the pain will be reproduced on palpation, of course. Okay, when you give pressure, the pain will be reproduced. But don't start rotating the hip internally, externally, both directions. Okay, one might be aggravating the problem, the other one might be correcting the problem because you are rotating hip in both the directions, means. Okay, and after your release, the patient will have a soreness, and then you will end up keeping ice cube massage or the IFT after the release, because patient got that sharp pain which was there, localized pain, has become diffuse pain. Because we have not pathomechanically differentiated whether this subject has pain on walking. Walking is what? It's only 20-degree flexion extension. Okay. If the pain comes, that means piriformis external rotator action. Stair climbing, hip is 90. So a patient telling pain on stair climbing, a piriformis syndrome patient telling pain on stair climbing means it is as internal rotator it is acting. Okay, because it is 90-degree deflection. So there comes the basic applied pathomechanics of the piriformis paradox. Why paradox? Because it is external and internal rotator at the same time. This type of paradox is there in iliotibial band also. Okay, it can extend the knee or flex the knee depending on whether the tendon, the line of action is anterior or posterior. For example, if you externally rotate the tibia, it will become a flexor of the knee. If you internally rotate the tibia, it will become an extensor of the knee, iliotibial band. Okay. So IT band also there is a paradox. I don't think anybody would have told this in old UG, PG, or even those who have done PhD in the knee joint also, they will not know. Same thing with, of course, the piriformis paradox also, and the pathomechanical part. Okay, those who are telling needling, that means what position you have to keep the muscle for needling. In AOMPT, we emphasize that you keep the muscle in the relaxed position, then you needle. Okay. If you are keeping it in the stretched position, elongated position, you can needle, no problem. But for that, you should know what is the pathomechanics, whether it is the flexion pathomechanics or extension pathomechanics. Okay. Walking is producing the gluteal pain, or stair climbing is producing the gluteal pain. Some patients tell after full squat, they fully squat on the ground and they get up, they feel the catching with the pain in the gluteal region. Okay. Or after the toileting, whether it is Western or Indian, anyway 90-degree flexion comes. So you know that this is flexion pathomechanics. Compared to a person who is skipping, okay, hip is extended, or basketball, any kind of sports, volleyball, okay, you are propelling with the leg and you are jumping. So these type of athletes, those who have also hip is extended, okay, they are not having hip flexion. So long jump means subject is going to land on the leg, okay. So that means one leg is extended, other leg is flexed. So landing leg, when they land on both the legs. But when they launch themselves, they go pushing with one leg and other leg take off. Okay. So one leg only they go. Landing both the legs. So that pushing leg piriformis syndrome, that means hip is extended. Okay. Landing time piriformis symptom comes, that means hip is flexed. So a long jumper having piriformis syndrome also, you should ask whether it is the propelling leg or during landing time. Okay. So that's where you actually become a clinician. You actually individualize for each and every patient. Okay. Otherwise, you become a technician. You do the same thing for all the patients. Okay. That's what the AOMPT we are trying to emphasize. Okay. And I think unfortunately Ritu ma'am is not able to join because of the internet connectivity. Okay. Did she text here in the comment? Yeah. I think she's not even able to see us. Okay. Poonam, you are clear that audio and video is fine. Yes, perfect. Okay. So coming to what exactly we do, how do we understand the piriformis syndrome? Again, it is articular, myofascial, and neural. So that means what are the articular? The sacrotuberous ligament. If that is gone for a lengthening, or sacrum dysfunction, okay, which we saw in the previous session today. If sacrum unilateral extension is there, that dysfunction can be caused by a tight piriformis. If unilateral flexion of the sacrum happens, okay, so unilateral flexion of the sacrum happens, that will lengthen the piriformis or it will keep it taut. Okay. Remember, a muscle being tight and taut, you should be able to differentiate this by taut means this is taut. Okay. Lengthened. Tight means this is tight. So you stretch means a tight muscle will lengthen. Okay. Or also you give contraction of the muscle. Okay. So this is tightness. Okay. You give contraction, relaxation, it will lengthen. So that is tight muscle. Taut means lengthened already. So how can you lengthen? And you give contraction also, length will be same. Okay. So that is taut muscle, T-A-U-T. So that is strain of piriformis. It got lengthened and then it has got micro trauma, inflammation, develops a trigger point. Strain of piriformis. Okay. That also can be a piriformis syndrome. Tight, okay, and shortening, adaptive shortening of the piriformis. So that creates less blood circulation to the piriformis because piriformis is twisted. Okay, so blood circulation will get reduced when it is tight. So that creates again the symptoms to arise from piriformis, because when blood is not there, how the muscles can work effectively. So little bit you work also, they will go for the heat generation excessive, and that will create a trigger point. Or a tight muscle can also entrap the sciatic nerve, which is coming down, leading to pseudo sciatica. Okay, clinical presentation. Pain along till the foot. Okay. So what we do? We do an SLR. We might do an SLR. In AOMPT, we activate the piriformis in SLR to confirm whether cause of the sciatica is piriformis. We just don't do the SLR alone. See, pain comes. Don't check the piriformis muscle length alone. No. Okay. Contract the piriformis in SLR position. Contract the piriformis. If the pain increases, numbness increases, you know that piriformis is the culprit. Or when you activate the piriformis, if the numbness reduces, okay, numbness is there in the foot. You have done the SLR. You activate the piriformis. If the numbness worsens, it is tightness of the piriformis, so numbness is increasing. You are activating and the numbness reduces. That means it's tautness. The muscle was lengthened. So you are activating the piriformis, it is coming to the normal length of the piriformis. So that will relieve the numbness in the foot. So that is why these things are not mentioned by anybody. Okay, those who are taking all piriformis courses. Okay, just to keep ourselves alerted on this type of a content. Okay. So when it is taught, okay, what essentially happens is an innominate dysfunction. Okay, I have told you that piriformis is from sacrum to the hip. Okay, imagine that I create the piriformis like between these two fingers, little finger and the thumb. Okay, so this is the piriformis muscle. Okay, so now innominate is like this. Okay, so that means what will happen when the innominate is like this and piriformis comes like this. So you get innominate dysfunctions, iliac dysfunctions. It will actually affect the piriformis mechanically. Okay, and also sciatic nerve, which is here, will also get compressed. My finger. Okay, so innominate dysfunction can affect piriformis directly, although piriformis is not attached to the innominate. Okay, the ilium. So sacrum dysfunction, hip dysfunction also. For example, femur is here, and if the hip is internally rotating, why it will internally rotate? Because of a femur anteversion. Okay, the torsion, femoral torsion, upper end. The anteversion is more. So what femur will do? It will try to keep the acetabulum to the head of the femur. So head of the femur, anteversion is there. It will internally rotate more so that it can be inside the acetabulum. Same way retroversion, that means the humeral head is more posterior. So this is lesser tubercle, posterior. So this is retroversion. In this scenario, to keep the femoral head inside the acetabulum, it will externally rotate. So that the femoral head will be inside the acetabulum. So these kind of problems will create piriformis to be tight or taut. Because tightness comes in internal rotation or external rotation depending on hip position, okay, whether it is flexion or extension, okay. And also, if hip is internally rotated, it will create internal rotator tightness and external rotator tautness, okay. So that is why combined assessment is important. Hip antiversion, how you can find? It is also by internal rotation assessment only in prone. Another thing is posterior dislocation. Subjects, you flex and adduct the hip. Okay, flex and adduct the hip. It will be going into tuck tuck sound will come. So people will do flexion and adduction. Tuck, it will dislocate. Again, when they do abduction, the dislocated one will reduce. Congenital dislocation of the hip. Hypermobility. Okay. Whenever it is there, it's because of acetabular dysplasia. Acetabulum is not that much deep. Developmentally, it's shallow. That also will cause piriformis to go into a trigger point. Because the joint fulcrum is not normally mobile, it's hypermobile. If the joint is properly stable, it will work for movement of the joint. If femur position is flexion, 90 degree, it will be an internal rotator. When it is extended, it will be an external rotator. Okay. So, but this will be disturbed in a situation where the joint itself is hypermobile. Okay. So, right from hip instability and also the weakness of the gluteus medius and the minimus. These two are the stabilizers of the hip. Abductors, external rotators, and extensors of the hip. So their weakness will again make the joint to be unstable because of the force closure. And the ligament laxity, ischiofemoral ligament, or the acetabular dysplasia, or slipped capital femoral epiphysis, Perthes disease, all this will cause a posterior instability of the hip, which can also affect the piriformis. So, at this juncture, of course, I want to verify whether my audio is fine from Dr. Narendra Verma or Dr. Chirag. Ritu ma'am is telling low internet. Okay, so that people understand that. Right, audio video is clear. Are you able to watch me? Are you able to hear me? Because Poonam also has bad internet. If nobody is connecting, okay. Chirag is saying audio and video both are fine. Okay. Do you feel like it is interrupted and then it is coming? Kushi is telling, yes sir, you are audible. Okay. Right. Right. Just alert me in case if I go off the screen or off the audio. Okay. Immediately put it in the comments. Okay. So, okay. Ritu ma'am is texting. Okay. So she is able to see me, but she is not able to be on the screen. Okay. So, hip evaluation, sacrum evaluation, both are important because we know pathomechanically both are linked. Articular also, myofascially also, gluteus medius and minimus weakness. And as you also have to note that the piriformis, its origin extends to the coccyx. Even the sacral carnua or the coccygeal carnua, Okay, the projection here. Till here the origin comes. Okay, the piriformis. So that's why in coccydynia also you will find piriformis dysfunction. Okay, especially the lateral dysfunctions of the coccyx. Okay, piriformis can also be dysfunctional. One side tight, another side taut. Okay, you can always find that. Okay, the same thing happens in sacral torsion, sacral unilateral flexions. Okay, or extension dysfunctions. Okay. So what do you actually assess? Okay, in a piriformis, as I told that it is the rotation component which you are assessing. Okay, so you check in the prone lying position. Okay, hip is neutral, and from here, imagine that if this is the tibia, okay, in the prone lying, I will do like this. Means it's an internal rotation of the femur, so that will elongate the piriformis. The same way, I can contract the piriformis by giving resistance to push inwards. Okay, so that will be an external rotator activity. So that will be contracting the piriformis. The same if the subject is supine and hip is flexed 90 degree. Okay, compared to the other side. This is the tested side, and here the tibia is there. Okay, that means tibia comes like this. It's an external rotation, and that will elongate the piriformis. Okay, tibia goes out, it's an internal rotation that will actually activate the piriformis. Okay, so pushing outside here will activate, and taking it inside or medially, the tibia alone medial, but the thigh is externally rotating. It will lengthen the piriformis. Okay, so both are to be done, and we have techniques in AOMPT utilizing the therabands, which we put around the femur. Okay, we can pull the theraband selectively in different planes in order to activate the different group of muscles. So piriformis can be functionally activated even during a squatting, sit to stand, or stair climbing, or one leg standing. Because many patients also complain that piriformis syndrome, they feel pain when they are weight bearing the leg. So you know that piriformis activity, it has to be modulated. It has to be either inhibited or it is taut, means it has to be activated. So you can use the theraband to either activate the piriformis or inhibit it by activating the adductors. Okay, because adductors are reciprocal, the antagonist. So you activate the adductors, it becomes inhibition of the abductors, including medius minimus and piriformis. And the characteristic location where you palpate for the piriformis, PSI is the posterior superior iliac spine to the greater trochanter. So there is a line. Okay. So if I have to keep, so one line connecting posterior superior iliac spine to the greater trochanter. Okay, and another line connecting ischial tuberosity to the ASIS, which is on my cheek. So I keep like this. Okay. Okay. So these two lines intersecting at one location. That's here. Okay. So that intersecting location is the one where you will palpate for the trigger point of the piriformis. The most important thing, commonly what clinicians do mistake, they just palpate the trigger point. After that, they do the strength testing, they do the flexibility. But what I suggest is, when your elbow is on the piriformis, at the same time you do the flexibility and the strength evaluations. You activate the piriformis concentrically and eccentrically using the theraband. All this we have described in the courses. Okay, in our AOMPT courses, we have gone into depth of evaluating and treating piriformis syndrome using open kinematic and closed kinematic chain in half kneeling position, and then with trunk rotations, sacral corrections with and without piriformis contractions, cock coccydynia treatment with and without piriformis contractions. So we have explored the pathomechanics in the best possible depth, okay, in our courses. So interested manual therapists and also physical therapists whom you are actually envisioning that I should do my best with my knowledge, okay. It's not like any patient will improve, okay. You just talk nicely to the patient will improve. They'll feel better. So patient improvement is not a criteria of your skill. What you know in that improvement, how it has improved, why the problem will not come back, okay, that is your pathomechanical understanding, your perspective. So that is the knowledge, okay. Without knowing, everybody will improve. Don't keep that improvement as a measure of your success. Whether I know that improvement will happen, that means you are knowledgeable enough that you deserve that success. So that is through enrollment of the courses. If anybody teaches better, do their courses. No objection at all. But even if you have done multiple courses, you will always find an AOMPT webinar being an extra knowledge than those courses. So that is the reality. Webinar itself. So imagine a clinical certification course, how the videos will be, or the direct offline workshops, how the experience will be. But this workshop, which is going to happen at Bangalore, the 11th and 12th of August, the Friday, Saturday coming up, is of course, it's a 2-day demonstration on all the clinical pathomechanics. So that means it is like all the regions pathomechanics. So we'll show 1 or 2 conditions, the challenges or the modifications, how it influences. That means like one is kinetic, another is kinematic, and we'll do different conditions because we have almost 20 conditions to cover in the 2 days. But if you see the detailed content, definitely all these pathomechanics webinars which we are taking daily, 25 webinars, will definitely adequately provide you a baseline theoretical content or an awareness, eye-opening, enlightening. But the specific courses, Piriformis syndrome also we have a special course, separate. Sacral dysfunction separately, ileum dysfunction separate. Each one has pathomechanics 1 hour and 2 hours of manual therapy, including all the adjunctive methods and functional treatment. Functional treatment, which is like day 1, you can make the patient to squat again. The Piriformis syndrome, again stair climbing, because we interlink the body structures through articular, myofascial and neural dimensions of pathomechanics. So tight muscle and taut muscle both can affect sciatic nerve. You can distinguish it in the SLR and then Piriformis activation. And the same way you see for Valet syndrome, that's a direct compression on the muscle belly. That is ischemia. But you also know that hip is in 90-degree flexion. When you are sitting valet, big valet, okay, so its inflection is more than 60 degree. So that means it is a internal rotator. So Piriformis will be tight in internal rotation, and when you do external rotation, it will be getting stretched. And you have to treat this patient in hip flexion, because flexion is the pathomechanics. You have to treat them in hip flexion. So, of course, Ritu ma'am is saying your side it is fine. Okay. So madam will be thinking like, you know, I missed the opportunity to be on the screen. Of course, more than that, of course, it's not madam missing a knowledge. Knowledge will miss madam. Okay, so it's like that. Right? I think Sujanya also is still not able to come back home, and she is not ready to join. It must be almost midnight for her. So we must be getting our way to close this session with the rehabilitation implications of myofascial. Means not only myofascial release techniques, it is also gluteus medius and minimus eccentric control training. Okay, so that's the component there. And then when it comes to neural, you are using sciatic nerve sliders or tensioners, but ensure to release the piriformis or activate the piriformis during the neural techniques. Articular, sacrum correction or hip joint gliding also. So you can glide definitely. Okay. So when you have the hip joint, you can give a anterior glide or posterior glide, or you give a distraction to the hip or compression also to the hip. Okay. So there are glides. Even mobilization with movement can be done for the hip joint. So these are all articular picture. Sacrum also mobilization with movement can be done, and the chiromanual activator. So activator method, AYMPT's signature approach of chiropractic is called as chiromanual therapy. So through that also you can explore sacral corrections in presence of piriformis activation. Okay, so that you can get a better clarity or understanding of the body's pathomechanics as evident as you are individualizing your approaches for every patient, okay, from their history into clinical presentation. Okay. So yes, Ritu ma'am, so we'll be closing the session, a short session compared to, of course, the sacral dysfunctions, mainly because, of course, I don't have anyone here on my screen. Okay. So it keeps you, more enthusiastic when people are joining. And of course, anyway, half an hour, it's definitely good and fine for all these webinars which we are taking, 25 pathomechanics webinars. So stay tuned with the AOMPT. If you are joining as a free participant, you are just viewing the free webinars. You stay connected here on the Instagram, you get the notification when we go live. But if you really seriously feel like I should be justified as a clinician, I should know the pathomechanics. And I don't think in India anyone takes courses on pathomechanics. Okay, in the history of physiotherapy profession, not only in India, leave about India, the whole world, okay, pathomechanics courses are exclusively provided one and only by the Academy of Orthopedic Manual Physical Therapists. So good luck to you all. Of course, God bless you all in plenty to make the best decisions of your life so that you can be the best therapist for all your patients. Okay. So bye-bye. I thank the inputs provided by Ritu ma'am, of course, in the comments. And let's get on with more and more interesting pathomechanics sessions in the future. Right?